Hello everyone, welcome to my video channel. Today we are going to cover regarding a prosthetic joint infection PJI, a part 1 video. In exams, you should be able to answer this question. 1. Define the prosthetic joint infection based on MSIS criteria. 2. What are the risk factors for prosthetic joint infection? 3. How do you prevent the risk of prosthetic joint infection? 4. What is the first stage replacement arthroplasty? Number 5. What is the second stage of replacement arthroplasty? What is the advantage or disadvantage of first stage versus second stage? So what is the interval between the first surgery and second surgery in the second stage replacement arthroplasty? Number 8. What antibiotic contained in the cement impregnated PMMA? Number 9. The maximum antibiotic that can be added in the cement before the cement integrity become compromised. It is part 1 video. In part 2 mostly will cover regarding the management. A part of this presentation, some of the credit goes to Miss Joanne. Okay, now let's begin. The definition is based on Musculoskeletal Infection Society MSIS criteria for prosthetic joint infection 2011. Prosthetic joint infection is present when one major criteria exists or 4 out of 6 minor criteria exist. The major criteria include whether there is two positive periprosthetic cultures with phenotypically identical organism, or presence of a sinus tract communicating with the joint. For the minor criteria involve either elevated CRP and ESR, elevated synovial fluid, white blood cell count, or positive change on leukocyte esterase test strip. Elevated synovial fluid, PMN, polymorphonuclear cells, presence of purulence in the affected joint, positive histologic analysis of periprosthetic tissue, a single positive culture. For microbiologic testing, the tissue culture obtained from representative periprosthetic tissue or fluid. Each sample should be taken with separate sterile instruments. 3 to 5 specimen culture samples are incubated in an aerobic environment. For the serum test, the ESR should be more than 30 mm per hour or CRP more than 10 mg per liter. What is the classification of prosthetic joint infection? The classification can be divided based on the pathogenesis, whether it is exogenous or hematogenous, or based on the timing of the clinical presentation. Prosthetic joint infection can occur anytime post-operatively. Based on the time interval between the surgery and the onset of clinical manifestation, PJI, prosthetic joint infection, can be divided into 4 stages. 1. Stage 1 or early PJI. The symptom starts within the first 4 to 8 weeks post-operatively. 2. Stage 2 or delayed onset of prosthetic joint infection. It presents 3 to 24 months after the surgery. 3. Stage 3 or late onset of prosthetic joint infection usually occurs 2 years post-operatively. Number 4, stage 4 or silent prostatic joint infection, a condition in which a positive culture is captured at the time of revision in a patient with no symptom of infection. Red flag patient. Be careful in patient in whom the criteria may be inaccurate. Example in adverse local tissue reaction ALTR or metal on metal hip implants. Crystalline deposition arthropathy, inflammatory arthropathy flare, infection with slow-growing organism. Example including Propionibacterium acnes, coagulase negative staphylococcus. One of the methods to confirm a prostatic joint infection is prosthesis sonication. Sonication means disintegration of biofilm of removed arthroplasty components using a low-frequency ultrasound, around 35 to 40 kHz, and the subsequent culture of the sonication fluid. It improved the microbiologic diagnosis of periprostatic infection. It improved the yield in culture-negative PJI. It is more sensitive than conventional periprostatic tissue cultures. It is study done by K.J. Bozzi et al. 2005. This picture illustrates the protocol for sonication of prostatic units. A. Sonication tube, a glass cylinder with the implant. B. Sonication apparatus with the sonication tube and implant within the sonication tank. Blood culture bottle taken from a joint fluid aspiration. Multiple studies showed a better yield result, more sensitive than conventional method. The yield result faster, shorter time to positivity. Around 95% organism is detected within 3 days, 100% within 8 days. For anaerobic cultures, 96% within 5 days and 99% within 10 days. This is quoted the study done by Angela M.M. et al. 2014. This picture shows types of Bacterial bottle culture vials. For prevention of prostatic joint infection, recommendation from ICM International Consensus Meeting, Philly 2018. Number 1. Identify the host risk factors. These include uncontrolled diabetes mellitus, rheumatoid arthritis, inflammatory arthropathy, renal impairment, malnutrition, morbid obesity, pulmonary disease, pre-operative anemia, peripheral vascular disease, excessive smoking, post-traumatic arthritis. The reason for each of the factors are explained in my previous videos, wound healing and surgical site infection. Number 2, medical optimization of the host. HbA1c more than 7%, there is an increased risk of prostatic joint infection around 2.31%. The blood sugar level more than 11.1 millimole per liter, there is a 2 times increased risk of prostatic joint infection. Number 3, bacterial decolonization. Pre-operative skin cleansing, whole body bath with antiseptic agent, and the night before with chlorhexidine gluconate wash. Number 4, hair removal. There is no evidence to support the role of hair removal in reducing risk of surgical site infection. Hair removal using razor has higher rates of prosthetic joint infection compared to hair clippers. Number 5. Pre-operative skin preparation. Chlorhexidine gluconate has a long-lasting cumulative effect against gram-positive and gram-negative. For alcohol-based solution, is a very good antimicrobial agent, but inflammability and discontinued effect after drying. Povidone iodine, the effect against the skin flora, relatively ineffective upon contact with blood and shorter duration of activity compared with chlorhexidine gluconate. Number 6. Draping. There is strong support in the literature for the use of plastic adhesive tapes for draping the surgical site. Cloth drapes shows 60% contamination versus the plastic adhesive drapes, around 6%. Either for incorporated drapes can reduce the wound contamination. The rate of surgical site infection is still the same. Number 7. Antibiotics in cement. Antibiotic impregnated PMMA can reduce the risk of prosthetic joint infection. Polymethyl methacrylate PMMA, also called a bone cement or acrylic bone cement, is widely accepted carrier material for local antibiotic delivery that is able to exceed the required MIC, minimal inhibitory concentration. Some antibiotics can influence the orientation and the cross-linking of the polymer chains, resulting in changes in the viscosity after mixing, the polymerization time, concentration of incorporated antibiotics, and the mechanical strength and stiffness of the PMMA. In addition to the effect of antibiotics on PMMA, the PMMA can influence the effectiveness of antibiotics as well. Antibiotics have to be 1. Heat stable due to the exothermic polymerization reaction. Number 2. Water soluble for the solution out of the PMMA. Number 3. Available in powder form for admixing them into the polymer powder. Number 4. Bactericidal, a broad spectrum, and have low risk of resistant induction, hypersensitivity, and or allergies. Example is vancomycin powder. So, partly answered the question earlier. Number 8. Blood conservation. Allogenic blood transfusion increase the risk of surgical site infection or prosthetic joint infection. Correcting the pre-existing anemia decrease the risk of transfusion. Please, good use of tranexamic acid. Number 9. OT traffic, operation theatre. The higher OT traffic will increase the load of airborne microorganisms. The more door openings can increase the rate of surgical site infection. Number 10. OT environment. The humidity should be around 20 to 60%. The temperature is around 18 degrees Celsius plus or minus 2 degrees Celsius. Number 11. The duration of operation. The risk of prosthetic joint infection has direct link with the duration of the surgery. The longer the surgery time, the higher the risk. The surgeon's case volume has a potential effect on the rate of surgical site infection. There are better muscle memory, higher retention, and faster recall. In lower case volume surgeon, it has higher rates of infection. Number 12. The medical equipment. Givisis et al. Investigated the contamination rate of suction tips and tried to correlate it with the development of subsequent deep wound infection. The authors reported the suction tip contribute around 54% rate of contamination. It is recommended to change every 60 minutes. The glove tip have around 28.7% rate of contamination. Recommended to change glove before prosthesis implantation. Regarding prophylactic antibiotic, number 13. Prophylactic antibiotics are one of the most common factors in preventing a prosthetic joint infection. Study done by Fogelberg et al. 1970, the incidence of infection was 1.7% in the group receiving antibiotic versus 8.9% in the group that did not receive antibiotics. The study also demonstrated that methicillin-resistant Staphylococcus aureus (MRSA) infection were increased in the antibiotic group, demonstrating the fine balance between the appropriate usage of antibiotics and its overuse. The American Association of Orthopedic Surgeons (AAOS) published a guidelines of prophylactic antibiotic. The optimum time for prophylactic antibiotic administration is within an hour prior to the surgery in order to reach the minimal inhibitory concentration (MIC) in the end organs during the operation. The second dose of antibiotics is given in prolonged surgical duration beyond the half-life of the antibiotic or when excessive blood loss occurs during the surgery. Yay, we have reached to the end of this video. I'll see you in part 2 of this video. Take care and bye.